okay, that facilitate gas exchange, allowing the body to take in oxygen and expel carbon dioxide. So basically, primarily, this is the reason why we have the respiratory system. Okay, God designed our body and placed this system in us. Okay, that we'll be able to what? Engage in gaseous exchange. You get it? So we take in oxygen, we breathe out carbon dioxide, basically. So it consists of what? The lungs, the airways are the trachea, bronchi, bronchus, okay? The diaphragm and associated structures like the nose, the mouth, and the throat. That helps us to achieve its work. So now, how does it work? So when you inhale, air enters the nose or the mouth, okay, and then travels down to the trachea. Then from the trachea, it goes into the bronchi, okay, which branch into smaller and smaller areas, which is the bronchus within the lungs, okay. Then at the end of the bronchus are the alveoli, where oxygen, diffuses from the air into the bloodstream, and carbon dioxide also diffuses from the blood into the alveoli to be exhaled. So we are learning the mechanism of what? Let me say gaseous exchange. Okay. So when you breathe in the oxygen and get to the alveoli, there must be diffusion. So the air diffuses into the bloodstream, and the carbon dioxide will also diffuse out of the blood outside, and then it's being exhaled. Okay. Now the diaphragm and other muscles work together to control the expansion and contraction of the chest cavity, allowing the movement of air into and out of the lungs. So this is basically what you should know when we say what? Respiratory system generally. Okay, you should know this. Okay, all right. So now these are, let me say, some key parts associated with the respiratory system. Now you should know, okay, so you have the upper respiratory tract. It includes the nose or the nasal cavity, then the pharynx or the throat, and the paranasal sinuses. Okay, so that makes up the upper respiratory tract. Okay, the nose, the nasal cavity, pharynx, and the paranasal sinuses. Then we have the lower part or the lower respiratory tract, comprised of the larynx, the trachea, the bronchi, the bronchus, and then the lungs. Okay, that is the lower respiratory tract. Now let's look at the lungs. The lungs, that is the main organ of the respiratory system, responsible for gas exchange. Okay, the main organ. If you talk about respiratory system, the main organ is the lungs. Okay, the main organ is the lungs. Okay, that is responsible for gas exchange. You have the diaphragm. The diaphragm is what? So please, you can see the picture on my screen, right? Good. You can also see the picture on my screen. The picture gives you an idea of where each of them is located. The diaphragm is a large dome-shaped muscle that plays a crucial role in breathing by expanding and contracting the chest cavity, pulling in air and pushing it out. Okay, so the diaphragm is very key. So as you'll be learning some conditions very soon, you realize that if there's something wrong with the diaphragm, it affects your oxygenation because it expands and contracts, okay, pulling in air and pushing it out. So if you have an issue with it, it really affects your oxygenations. Okay. Then you have the airways. Okay. They are a network of tubes that carry air to the lungs, including the trachea, the bronchi, and then the bronchioles. Okay. Good. The alveoli, these are tiny air sacs within the lungs where gas exchange takes place between the air and then the blood. I think I spoke about it just now by the help of what? Diffusion. Okay, by the help of diffusion. That is how gas exchange is being what? It's been done. So generally, this is what we say, or when we talk about respiratory system, this is what you should know generally, okay, about the respiratory system or respirology. Okay, very good. Now we are zooming into the conditions. As I said, we are going to focus on the key ones that we should be expecting for our NCLEX. Okay, all right. Any questions so far as we start the conditions? Any questions so far from what you've learned? All right. I don't think there's any question. Okay. All right. Yeah, Mr. Karim. Mr. Karim, I saw your hand. Or it was a mistake. Yes, unmute and talk.
Okay, so thank you, boss. Yes, I want to find out with regards to the diaphragm.
Mm.
Sorry. So on inspiration and expiration, what happens to the diaphragm?
You want to know what occurs to the diaphragm during inspiration.
And expiration. I saw a question like that. Yes, please.
Oh, okay. Okay. All right. So the diaphragm, when you inhale, this is what happens. Okay. So anytime you breathe in, okay, the diaphragm contracts. So the diaphragm muscles shortened, okay, and then they move downwards. When you inhale, they contract, okay, and they move downwards, okay. So the flattened diaphragm increases the space in the chest cavity, also in the thoracic cavity. Then the expansion of the chest cavity reduces the air pressure inside, making it lower than the air pressure outside the body. Okay, I don't know if I'm getting the picture. So anytime you breathe in, the muscle fibers in the diaphragm shortens and then they move downwards. Okay. So in doing this, it causes what? The expansion of the chest cavity, which reduces the air pressure inside. Okay, making it lower than the air pressure outside the body. Then with this, the pressure difference between the outside air and that of the chest cavity will cause the air to flow through the lungs, okay? Into your lungs, through your nose and the mouth. Are you getting it? So when you breathe in, there is, some kind of what? A shortening of the diaphragm, and it moves downwards. When it moves downwards, there is changes in pressure, okay? So the pressure in inside, okay, the air pressure inside becomes lower than the pressure outside. So due to this, it causes air to flow inside, and then there is what? Breathing in. Now, when you are breathing out, the muscle fibers now relaxes, of the diaphragm relaxes, okay, allowing the diaphragm to get that dome shaped, okay, or dome shape, okay. So this also reduces the space within the chest cavity. Are you getting it? The reason why the chest cavity expands or enlarges in breathing in, because you are breathing in air. When you are breathing in air, for example, imagine a balloon. You are blowing air into a balloon. Anytime you blow air into a balloon, what happens? The balloon swells up. That is why there is what? Expansion in the chest cavity in breathing in. Now, when you are breathing out, the diaphragm also relaxes, okay, to squeeze it a bit to assume that dome shape, okay. So that decrease in the chest cavity reduces the pressure inside. Sorry, increases it rather. Okay, so that reduce or decrease in the chest cavity increases the air pressure inside, making it higher than that of the body outside. And then if that one too, that changes in the pressure, the air now can flow out through the lungs and then comes out through your mouth and then your nose. Please, did you get it?
Yes, please, boss. So if I get you in brief, it means that on inhalation the diaphragm moves downwards, and then on
Yes,
exhalation it moves upwards.
exactly.
Okay,
Yes.
so that was what the person was asking about. Okay, all right,
Oh,
thank
okay.
you.
You're welcome. So inhalation, the diaphragm will move downwards, okay, and then it flattens, okay. But in exhalation, it will move upwards, okay, so that it can
Okay,
help to bring the air out, okay.
all right, thank you so much. Thank you.
You're welcome. You're welcome. Any other question? Okay, all right. So now let's move on to our conditions to be expected on the end place, okay. Good. So COPD, okay, chronic obstructive pulmonary disease, COPD. I know it's a common topic. Most of us have an idea on it. Okay. We all know what COPD is, what occurs in COPD. Most of us, if I'm sure even all of us, we all know what goes into COPD. Okay, so it's going to be easy. Or let me say a kind of a revision, okay, for all of us. Okay. But we touch on some key areas that we should expect for our NCLEX. Okay. All right. So let's start work. Now, so when you talk about COPD, what is COPD? So we say it's a chronic obstructive pulmonary disease. Okay. A chronic obstructive pulmonary disease. So as the name goes, chronic, meaning the condition is a chronic something. Okay. It's a chronic disease. Okay, it's a chronic disease. And then now we have obstructive pulmonary. What comes into mind? Probably something is obstructing the airway. Pulmonary means lungs, okay? Something is obstructing the airway, okay? Something is obstructing the airway. So what obstructs the airway? We are going to dive into it. So when we talk about COPD, we say it is a progressive, irreversible lung disease characterized by airflow limitation, okay? It is a progressive, irreversible lung disease characterized by airflow limitation. It is a progressive, irreversible lung disease characterized by an airflow limitation. Okay, now in COPD, what is occurring in COPD? Let's deal with the pathophysiology of COPD. Once we get the pathophysiology, usually it's easy. Madam Jenna, please stop writing on my screen. Madam Jenna, please stop writing on my screen. All right. So now let's talk about COPD. So in COPD, we said two things are occurring: chronic bronchitis and then emphysema is occurring in COPD. Okay, chronic bronchitis and emphysema is occurring in COPD. Now, I will use smoking here because smoking is the leading cause of COPD. COPD, the major cause of COPD is smoking. Okay, so those who smoke a lot, like has become a chronic smoker for like 10, 20, 30 years smoking, are really what at higher risk for getting what COPD. So now you have been smoking a lot. Madam Yvette, please, you are repeating the same thing. Yeah, you're also writing on my screen. Okay, let's move on. Okay, so when you smoke, or let me say you have been smoking for a while now, or a longer period now, when you consistently smoke and then you are inhaling those smokes, okay, the substance containing this cigar, tobacco, you are inhaling them. What occurs is that when it gets to the airway, it causes inflammations in the airways. Okay, it causes inflammations in the airways. So the bronchioles, which is part of the airway, the smaller tubes, becomes inflamed. Now, the moment inflammation sets in, we all know the 5 signs of inflammation, right? 5 signs of inflammation. We have what? Pain. We have pain. We have what? Edema. Very good. So pain, swelling or edema, right? So pain, swelling, redness.
Impalpable cord, venous cord.
Are you sure? So we have basically 5 signs of inflammation. Okay, so there is pain, there is swelling, there is warmth, there is redness, and loss of function. These are the 5 signs of inflammation. Okay, pain, swelling, redness, warmth, and loss of function. So when there's an inflammation in the bronchioles, how the bronchioles function is going to be what? Affected. You get it? It's going to be affected. So there's going to be what? Mucus production, because there's going to be swelling and edema. Don't forget. Inflammation sets in, there's release of what? Inflammatory mediators. These inflammatory mediators act on the airways and they cause mucus production because there's going to be swelling and edema. Okay, so a person smokes and then because has been smoking for long, eventually the smoking have impact on the airway, causing inflammation. Now, this inflammation causes what? Swellings due to release of inflammatory what? Substance or mediators, chemicals. And then they begin to cause what? Mucus production because there is swelling. You get it? So that is how we are going to get a chronic what? Bronchitis. So inflammation of bronchioles leading to what? Mucus production. Then we are going to have emphysema or emphysema. Okay, that one too is due to the inflammation that is going to occur. So consistent inflammations begins to affect the alveoli. So the emphysema deals with the alveoli in particular. The alveoli is made up of air sacs. Please let's take note. Okay, the alveoli is made up of air sacs. Now, the air sacs are elastic. Please, you must get this, okay? The air sacs are elastic. And now, we all use things which are elastic. Just imagine, I don't know what I can use, okay? But something that contains elastic. You see how when you stretch it, what happens? When you stretch it, it comes back, okay? Anytime you stretch it, it comes back. When you stretch it, it comes back. Anything elastic has that property. So when you breathe in, before carbon dioxide can come out in the normal person, the moment you breathe in, and then you are going to breathe out, the air sacs must what bring that elastic property to push the air out. Are you getting the picture? The moment you breathe in oxygen, and then now it is time for diffusion of carbon dioxide out of the blood to be exhaled out. That elasticity, what will have to help the air sac to push what the air out of the body, or the carbon dioxide out of the body. But in emphysema or in COPD, due to inflammation, the air sacs or the alveoli has become enlarged, so that elasticity property is not there. Are you getting the picture why we get air trapping in COPD? You breathe in the air, and now the elasticity of the air sacs to help push the air out is not there. So what occurs? The air is going to stay there. That is why you're going to get hyperinflation and air trapping, because that property of the alveoli of the air sacs to help expel the air is not there. So due to that, the air stays there. Okay, very good. So this is what is occurring in COPD, the general thing about COPD. So there's chronic bronchitis and there's emphysema. Okay, so you can see the picture on the screen. Okay, you realize that there's mucus production in the bronchioles, and then there's an inflamed bronchiole leading to mucus production. Yeah, so someone is saying a balloon. I'm seeing putting a stone in a catapult that you can stretch to shoot. Yeah, exactly. You get it. So that elasticity is not there, so it cannot come out. Okay. So we have the mucus in the bronchiole. When there's an inflamed bronchioles, are going to mucus production. Okay. And then when there is an enlarged or a blocked alveoli due to the inelasticity of the air sacs to push the air, there's going to be air trapping. Okay. That is that for COPD. Okay. The general thing you should know about COPD: chronic bronchitis, emphysema, inflammation of the bronchioles leading to what? Swelling and mucus production, and then alveolar enlargement, and then what? The air sacs losing its elasticity, leading to air trapping. I'm sure we are good. All right. So this is what we should know about COPD. Okay. Good. So now the causes or risk factors of COPD. So we have smoking. So as I said, smoking is the leading cause of COPD. Okay. Smoking is the leading cause of COPD. The major cause of COPD is smoking. When you smoke and smoke and smoke, eventually it begins to have an impact on your airway, and it can push you into COPD. Then we have air pollution. So exposure to air pollution, including secondhand smoke, can contribute to COPD. Okay. You yourself, you don't smoke, but consistently you find yourself in an environment whereby smoking goes on consistently, like the club, a sport or something. Okay. Or probably consistently you find yourself in an area they are burning things here and there, and then you are going to inhale the smoke. It can predispose you to getting COPD. Okay. Then you have 3 occupational exposures. So certain occupations like mining or construction can increase the risk of COPD. Of course, when you are in a mining environment, first of all, what comes into mind? You are dealing with heavy metals. The mining and those who are, in construction, or those they deal with heavy metals. Okay. So when you begin to inhale those heavy metals, it can also cause inflammations in the bronchioles and the alveoli, and can cause COPD. Just imagine someone who is in a construction site all the time. For example, those who deal with roads and all those stuff. And you go there, and every day they are on the road doing the road. They inhale dust, they inhale, a lot of particles all the time. All these things can eventually cause inflammations in the bronchioles, leading to mucus production or the alveoli, affecting the elasticity of the air sacs. Okay. Then we have 4, genetics. Now we have the alpha-1 antitrypsin deficiency. Now, what is alpha-1 antitrypsin? Alpha-1 antitrypsin is an enzyme. Okay. It functions like an enzyme. What it does is that it protects the lungs from infections. Okay. It protects the lungs from infections. This alpha-1 antitrypsin. It protects the lungs from infection. Okay. Alpha-1 antitrypsin. Now, when you have this, have the deficiency of this enzyme, it means that protection will be lost. Are you getting the point? That protection is going to be lost. The protection by this antitrypsin to help the lungs and protect it from infection is going to be lost. In this instance, any condition that should affect the lungs can attack it anytime, any day, because the defense is not there. Okay, and then usually, this alpha-1 antitrypsin is usually seen in kids. Okay, and they are born and there is a deficiency of this alpha-1 antitrypsin. They can get issues with their airway easily. Okay, that is why usually kids they get asthma and all those stuff. When a kid lacks some of these things, they can get asthma and then COPD and other conditions as well. Okay, Then lastly, we have history of childhood respiratory illness. So when you were a child, you used to get a lot of conditions like pneumonia, respiratory apparatus like cold and all this stuff consistently. It can predispose you to getting COPD as you grow. Okay, so these are the risk factors for what? For COPD. But mind you, among all these, the number one cause is what? Smoking. Okay, so when you get a question on your ankles, you must know that smoking is the number one cause of what? Of COPD. Okay. All right. Please, any question? Okay. Let's talk about the signs and symptoms. So one, we have shortness of breath. Okay, shortness of breath. So COPD can cause shortness of breath, especially during physical activity. Of course, see, when you breathe in air, the air passes through the mouth or the nose down to the trachea. When it gets to the trachea, it moves to the branches, the bronchi, the bronchus. Okay. So let me see. One is bronchus, but two is bronchi. It passes through them. Then when it gets there, it now moves further to the smaller airways. That is the bronchus before it gets to the alveoli. So before air will enter the alveoli for gaseous exchange, mind you, it passes through the bronchus. But here lies a case: the bronchus is inflamed, causing mucus production, limiting the amount of air entering. Are you getting the point? The amount of air entering the bronchus is limited because there is mucus production blocking the air sac, or let me say the air tubes. So a person will engage in physical activity and there will be shortness of breath because there's no amount of what? Oxygen entering what? The alveoli to even cause what? An oxygenation. And mind you, when you engage yourself in exercises, a lot of metabolism takes place. So there's increase in oxygen demand. Okay, when you are exercising, there's increase in metabolism. That one alone will push the oxygen demand up. And then you have COPD. There's mucus production in your bronchioles, so air cannot enter. Don't you get shortness of breath? I'm going to get shortness of breath. So that is why usually they experience shortness of breath with what? With activities. Okay. All right. Then you are going to get wheezing. We all know that wheezing is common in where? It's common in asthma. Right. But then you can also get wheezing in COPD as well because they all have that, line or that pattern of what? Disease formation or occurrence. Okay. In all of them, there is that mucus productions. You are getting it. So you are going to get wheezing. So you auscultate, and you are going to hear that. Or even, wheezing can sometimes becomes very, very loud to the point that you don't have to even auscultate to hear. How does wheezing occur? So we say wheezing or a whistling sound when breathing out can be a symptom of what? Of COPD. Are you getting the point? Now, how or why do we hear wheezing? That sound. It goes, when you hear that sound, it's like, the reason why we are hearing that is because the air is forcing itself to push itself out. Are you getting the point? The air must pass through the bronchioles to come out of the body, like carbon dioxide to come out of the body. So in that attempt to bring it out, because there's no airway, there's mucus production causing the bronchioles to be narrowed. It is closing. Mucus is blocking the airflow or the airway. So due to that, the body tries to compensate to push the air forcefully. Okay, I keep on saying that anytime there's something wrong, always the body will compensate. It is natural. So the body sees this actually, why am I not getting the air out? Let me push it so that I can get the air out. So that attempt to push the air out produces that wheezing sound. Then you see, Okay. So please let's take note. That is why you're getting wheezing. Then 3, coughing. A persistent cough often producing mucus is common in COPD. Once again, compensatory mechanism. There's mucus production due to inflammation of the bronchioles. So the body tells itself, Charlie, can't you see this is not what I grew up with? Can't you see this is what I was created with? I'm having mucus in my airway and I'm sitting down. Please cough and bring the mucus out. So it's a compensatory mechanism, okay? It's a compensatory mechanism. You get it? A compensatory mechanism to bring the mucus out, hence the coughing. Okay, hence the coughing. So when a patient with COPD coughs, it's simply because there's mucus production. So in an attempt to bring the mucus out, they begin to do what? They begin to cough to bring the mucus out. Okay, someone is trying to demonstrate the sound again. We must all do well to listen to the breath. The lung sounds very, very well. Okay, they are on YouTube and the rest. But wheezing is like, okay, that is how wheezing is. Okay, that is how wheezing is. And then crackles is just by the way, crackles goes like, pop, 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 pop. Okay, I once had a question like that. Okay, so please, this is just an advice. When you go to your ankles and they give you the headphone, please take the headphones. You don't know whether there is a lung sound or probably a heart sound you're going to listen to. Okay, because I remember those days I had a question like that, and then there was crackles in it. Okay, there was crackles in it for me to listen to and then identify the sound. Okay, so please let's take note. You must do well to you must do well to capture all the sounds. You get it? It's very, very important for our English. So that is why. So you have shortness of breath, wheezing, and coughing. Chest tightness. Chest tightness. So feeling like the chest is tight or heavy can be a symptom of COPD. All this is because there is what? There is a narrowing. There's some constriction. There's mucus production, inflammation occurring, causing the narrowing. Okay, air is not moving out. Air is not really coming out. It's not really getting in as it should be. All this creates like a heavy chest or chest tightness. Okay, so that is how you are going to get the chest tightness in COPD. Then 5, barrel chest. Barrel chest. A barrel chest. So now, once again, let's look at the picture. Okay, so now let's look at the picture once again. So here, okay, mucus production, air trapping. Keyword, air trapping. Okay, so in COPD, there is inflammation of the bronchioles leading to mucus productions. So the mucus is narrowing the airway. So please note, the volume of air entering the bronchioles is limited or is just small. And then once again, when the air gets into the alveoli, the air or the cannot be expelled out because the alveoli sac has lost its elasticity to even compel itself to push the carbon dioxide out. So what do you think is going to occur? All the air you are breathing is going to be trapped because there's no elastic to push the air out. So all the air you are breathing is going to be trapped in the alveoli. Eventually, imagine a balloon, you blow air consistently. What happens to the balloon? The balloon swells up. Anytime you blow air into a hollow space, it swells up. The lungs is made up of air spaces. Alveoli, bronchioles, they are all airways, air spaces, air. So because air is staying there for long, eventually they begin to swell up. And that's why you're going to get what? A barrel chest. Okay? Are you getting the picture? A barrel chest. So we see barrel chest in COPD due to the air trapping. The air is not really being pushed out. Okay? So they begin to accumulate and then they continue to swell up the lungs. And are going to get a barrel chest. And mind you, the lung is located beneath what? The chest. So once there's an increase in the size or an inflation in the size of the lung, it will definitely affect the chest. So there's a barrel chest. Then 6, fatigue. This patient is not going to get enough oxygen because there's narrowed airway. So if this patient usually used to breathe, for example, if this patient usually used to breathe like 5 liters of air at a time, now it has been limited to 1 liter because the air that should go in is being blocked by the mucus. So this person will not get that energy. I'm sure you all know we need oxygen for energy. Okay. We need oxygen for energy. So due to this, the patient will do something small and then he's getting tired. There's limited amount of air entering the lungs for even energy to be achieved. So anything that they do, they are being fatigued. 7, oxygen level is between 88 to 92. COPD patients, usually their oxygen level is 88 to 92. I will explain this more when we get to the next intervention. Okay. Then now you have cyanosis. Okay, cyanosis. Of course, if for a longer period of time you're not getting enough oxygen, you begin to turn blue. Okay, it's a sign of what? Deoxygenation. Okay, it's as simple as that. It's a sign of deoxygenation. So you realize that the patient's lips is becoming blue. Okay, and then eventually that skin also begin to turn blue. All these are signs of cyanosis, and it indicates what? Limited amount of oxygen. Then 10, weight loss. Weight loss. There is weight loss because this patient is not going to eat much. The reason is because this patient, the amount of oxygen needed to carry out a physical activity is not there. So even the energy to even eat is not there. It is interesting. Many people don't know that when you are eating, you need oxygen and energy because you don't have any respiratory condition. You experience some small asthma and see how you suffer when you're about to eat. Okay. So when you eat or when you're eating, you need energy. You need adequate oxygen to eat. But this patient lacks all these things. Okay. So due to that, eventually they don't eat plenty and it begins to cause their weight to drop. So they get weight loss. Then 11, tripod position for breathing. Let me show the tripod position. But before I show it, who can describe the tripod position for me? Who can describe it? Tripod position. Yes. Yes. Anyone to describe tripod position? Oh, please, can you hear me? Am I loud?
Yes.
Yes, quiet too. Who can describe the way
But
tripod position? Yeah.
let me try. So it's like when they are sitting, they lean forward.
And what again? Look for them. What again? You didn't bring the last one. So this is 50 over 100.
Hey.
Yes. Who get it? Oh, someone is saying we can't unmute. Why? Why can't you unmute? Please, if you want to talk, kindly raise your hand. Okay, I will ask you to unmute, and you can now unmute. I don't know why. Okay. So please.
Older children also.
Yes, one at a time, please. Who is speaking now?
So for the tripod position, you find the patient sitting sometimes at the edge of the bed. And then they normally have maybe a heart table in front of them, so they tend to lean on it with the two hands. So it's like leaning forward.
Okay,
then
so
it gives them that.
I'm listening.
It helps them breathe better.
Okay. Hey, go for it. Okay, so they lean forward and then they rest their hands on their knees. So it is two ways. Okay, it is two ways. It is two ways. They lean forward. When they are sitting down, this is what they do. They lean forward and then they rest their hands on their knees. It really expands the lungs to breathe. 2, they stand. And when they stand, they squat. Not as in squatting to bring all of yourself down, but then in the same idea, they lean forward and they put their hands on their knees. And then when the patient is in bed, this is how they do it. Probably a heart table, like we all know for what? For cardiac bed. You know, way back in school, when I was doing a cardiac bed, we say place or a heart table there. So they sit there and they lean on that heart table or a pillow. They rest on the pillow. It helps to expand the lung. So do you know when you know? Please, this is just something you should just know. Okay, when you see, you know someone who smokes a lot in the area, and then maybe you observe the person that from time to time you see the person walking and a point and the person relaxes. To do that tripod position, please start suspecting COPD. Okay, you know a chronic smoker in your area, from time to time you see them walking that way, or doing that type of position, you should start suspecting COPD. Or on your ankles, a 50-year-old man was admitted to your ward, and per the history taking, the patient verbalized that anytime I want to breathe properly, I lean forward and then I rest my hand on my knees. Please, this is what? COPD. Okay. It's a clear sign of COPD. So they use tripod position. So it's very, very clinical with them. Okay. It's a common feature with them. A patient with COPD. This is why they assume that tripod position for breathing, because it helps to expand the lung. I want to show the picture because you can get it on your ankles. Okay. They can bring that picture there for you to select. Okay. So let me try and see if I can show a picture of it so that we can all see on our ankles. When you see this, you know that this is what tripod position. Okay, so I think I've gotten one here. Okay, so let me. Please, can you all see my screen? Please, can you all see my screen?
Yes.
So this is the image, okay, of the tripod position. This is how it looks like. Okay, this is how it looks like. So please, let's take note. So they sit, they lean forward, or they stand, they lean forward, and they rest their hands on their knees. Okay, so this is a clear example of tripod position, and it's common in a patient with COPD. Okay, common in a patient with COPD. All right. Good. So, diagnostic test. How do we diagnose a patient with COPD? One, we use the spirometry. Okay, we will talk more. How to use the spirometry more when we get to asthma. Okay, when we get to asthma, we'll talk about it more when we get to asthma, the spirometry. Okay, but just know that it measures the volume of air in the lungs during inhalation. A patient with COPD has a narrow airway due to mucus production as a result of what? Inflammation of the bronchioles. So the amount of air or the volume of air entering the lungs at a given time is limited. So we can use this spirometry or the device to measure the volume, okay, of the air entering the lungs at that given time. It can give a clear notion of how to do what? To diagnose COPD. But mind you, usually in COPD, observe chest X-ray more. And this is what you see on the chest X-ray. A flattened diaphragm or a barrel chest or a hyperinflation of the chest. Okay, flattened diaphragm, barrel chest, or hyperinflation of the chest. I have explained this why we are getting the barrel chest, the hyperinflation. There is air. Air is being trapped. The air sac has lost its elasticity to push the carbon dioxide out. Okay, and even there is what? There is narrowed airway. So even if the air sacs try, not enough air will come out. Okay, so the air is being trapped consistently. This eventually swells up the lungs. So you are getting hyperinflation, barrel chest, and then now at a point in time, the air will begin to compress the diaphragm. You are going to get a flattened diaphragm. Okay, the air will begin to compress what? The diaphragm. So you are going to get a flattened diaphragm at a point in time. So please, let's take note. So you see on the ankle, you should be expecting some of these in the chest X-ray or diagnostic test. Okay, so when you read the history, like smoking, don't conclude yet, because conditions like lung cancer is also caused by smoking. Don't conclude yet. Okay, once you see the diagnostic test, you are able to figure out flattened diaphragm, barrel chest, hyperinflation. Please, automatically, it's I can say it is what? COPD. Okay, because some of these things the NCLEX will bring them regarding COPD. Okay, so that is that. Then lastly, you can talk about the ABGs. Okay, arterial blood gases. There's going to be an increased partial pressure of CO2 and a decreased partial pressure of oxygen. Okay, because all the carbon dioxide that should be expelled out is not coming out. The alveoli cannot now expel the carbon dioxide out. So carbon dioxide will begin to increase. Okay, carbon dioxide will begin to increase, and now oxygen will begin to drop. Because one, mind you, we are not getting enough volume of air into the lungs. Even the initial stages, we are not getting air enough into the lungs due to what? A narrowed airway. And then even when the air gets there, instead of it to be expelled out, it's not going out. So the carbon dioxide begin to increase. So low oxygen, high carbon dioxide. So please, I'm asking a question. What do you think is going to be the respiratory, let me say, the ABG analysis for patients with COPD? When you analyze the ABGs, what are you going to see? Yes, can you raise your hand if you want to speak? Okay. And I ask you to unmute. You know you can unmute. Yeah, okay, Madam Sarah. Yes, Madam Sarah, Madam Patience, you can speak.
There'll be respiratory acidosis.
Okay, respiratory acidosis. Okay. Okay, because there's increase in what? Carbon dioxide. So please let's take it. Yeah, so one of the key signs and symptoms of COPD is respiratory acidosis. I didn't put on my slide because I wanted to ask that question. Okay, so respiratory what? Acidosis, because there's increase in carbon dioxide. But please mind you, don't just, maybe they can trick you because it's an exam. They can trick you because it's an exam. Don't just go and see a patient with COPD presented with high levels of CO2, which is 55, and then what we do, please don't just see the CO2 and then conclude. There must be what? A difference in the pH. So what should be the pH level? Greater or higher than what? Or lower than what? The pH. Yes, Anna Sarah can speak. Yes. Yes, Mr. Karim, yes.
So the pH should be lower than 7.35.
Yeah, 7.35. Okay, please. I see in the chat box 7.4. Please, not 7.4. 7.35. Lower than that. Okay, lower than that. 7.35. Okay, all right, perfect. So these are some of the ways you can diagnose what a patient with COPD. More importantly, is the chest X-ray. Okay, a flattened diaphragm, a barrel chest, or a hyperinflation of the chest. Okay, all right, good. Now, nursing management. Nursing management. Please, any questions so far? Please, you can raise your hand. Then I can now ask you to unmute. Okay. Any question, please, so far from what you've learned? Okay. I think we are cool, right? We are cool. We don't have any question. Okay. So now, nursing management. So life. Okay, I have one. Madam Jennifer, yes, you can speak. You can unmute and talk.
Okay, thank you. Please, I want to know whether diaphoresis is one of the signs and symptoms.
Diaphragm is like sweating, right?
It's excessive.
Okay, so usually you see sweating or profuse sweating in a condition like tuberculosis. Okay, usually it's not really common in a patient with COPD, but it can occur when there is anxiety. Okay, when there's an anxiety, it's going to be those kind of diaphoresis, but it's not really a clear sign. Okay, in a person with COPD. Okay, but when anxiety increases, because you know when you are kind of experiencing some of these conditions, you can get anxiety. When anxiety increases, it can cause diaphoresis. Okay, all right. Yes, Sister Mimi, you are here. You are welcome.
So
Yes,
I wanted to talk, but I realized that I've been muted.
yes. I don't know why. I don't know.
I think that's the best. You can make me a co-host, okay?
Okay, sure. All right.
Okay, thank you.
You're welcome. All right, that is fine. Good. So now let's talk about the nursing management. So we have one, lifestyle changes. Okay, lifestyle changes. So quitting smoking, exercising regularly, and eating a healthy habit healthy diet. Yeah, I said healthy habit. Healthy diet can help manage what? COPD. So as we said, the leading cause of COPD is what? Smoking. Okay, So we must educate them to quit smoking. Consistently, we must educate them to quit smoking. Okay, we must educate them to quit smoking. Then they can exercise regularly. Okay, and then eat a healthy diet. We'll talk about the diet as you can see on my screen. We'll talk about it when we get there. Okay, so they must exercise regularly and then quit smoking to prevent or to help them to manage what? Manage the COPD. Then 2, we have what? Pulmonary rehabilitation. So education support to remove or to improve the lung function. Okay, educational support to improve the lung function. So we can engage them in rehab. You know, it's not easy to quit smoking. Are you getting it? It's not easy. So sometimes they might engage in those rehabilitations, especially with the lungs. Okay, they might see a pulmonist or something like that to help them what engage in how they can improve their lung function. Okay, all right. Then 3, oxygen therapy. So now let me explain why usually we peg a patient with COPD oxygen at 88 to 92. So we give them low oxygen, usually 1 to 2 liters with ventral mask to prevent respiratory drive depression. Okay. So now in COPD, let's know that this is occurring. The condition is chronic. Okay, it's a chronic condition. All right, well established. So because it is chronic, and then now there is low amount of oxygen going into the lungs, low amount of oxygen going into the lungs, okay, and then high retention of carbon dioxide because the air sacs are not pulling the air out. So eventually we stabilize this chronic, low oxygen, high retention of CO2. So now what occurs? At a point in time, because the condition is chronic, the patient begins to adjust itself to the low oxygen and high carbon dioxide for breathing. Are you getting the point? Okay, it's chronic, low oxygen entering, and then high carbon dioxide retention. So because it is chronic, at a long time or at a given point in time, the patient begins to adjust itself to the low oxygen and the high carbon dioxide for breathing. So this patient, when you increase their oxygen level, you are going to worsen the case because they've adjusted themselves to that low oxygen and then high carbon dioxide for breathing. They breathe because they have low oxygen. Even that is the truth. That is the reality. Patients with COPD, the reason why they can even breathe is because they have that low oxygen. They've adjusted themselves to that reality, okay, or that science. Okay, so due to that, we don't give them high oxygen. So you don't have to increase the oxygen to like 95, 97. No. So usually every day, 88 to 92. When you increase the oxygen level, you are going to worsen the case. It will decrease their respiratory drive because they depend on low oxygen and high carbon dioxide to breathe. So when you increase the oxygen level to less than 95, 96, that drive will be depressed. It will even stop them from breathing and it will worsen the carbon dioxide. It's even going to cause more retention of carbon dioxide, leading to hypercapnia. Are you getting the point? That is why usually COPD patients should get oxygen between 88 and 92, and then we deliver low oxygen 1 to 2 liters at a time. Okay, yes, for all patients with COPD. Okay, for all patients with COPD, usually for all patients with COPD, okay, they get that low oxygenation. Okay, if it's not okay, because sometimes conditions vary. Okay, but when you pick like 10 patients with COPD,
Hello, Bosaki.
yeah, it's not me.
I think you replied the person in the chat, but the person said, I don't think so. So I wanted to the person to give us the rationale why she doesn't think so.
Oh, okay.
Or maybe
Yeah.
when you are done. I think she replied that she doesn't think so.
Okay, you let me, when I'm done, I'll have a question.
Yes, exactly.
Okay. So usually, when you pick about 10 patients with COPD, most of them, about 9, are going to experience that CO2 retention. Okay, are going to experience that COPD retention. Few of them, I don't know, but okay, madam, is it Dorcas? Can you explain why we have some of them who doesn't really retain CO2 and then why they don't? Lucas, please, yes. Yes. Okay. So that's what I think I said. Okay. Conditions do vary, or let me say, everyone and how they respond to conditions or the disease. Okay. But majority, mind you, about 90% or 95% of patients with COPD are going to get that retention of CO2. Maybe a few portion of them or a few of them will not get that one, will not get that CO2 retentions. Okay. But usually most of them are going to get CO2 retention because the air sacs are not helping to expel the carbon dioxide out. That is why we give them a low amount of oxygen. Okay. So if you are asking the question, then just know that it's because of how individuals respond to conditions at a given time. Okay. Not everyone will experience that, but majority of them are going to get CO2 retention when it comes to COPD. Okay. All right. So that is why we give them the low oxygen, okay, to prevent the depression of the respiratory drive. So we use the venturi mask, okay. I'm sure you all know why we use the venturi mask. Someone should tell us why. How do you use the venturi mask in a patient with COPD? Yes. Why? Hello. Why do you use venturi mask? Yeah, okay, Mr. Karim, yes.
Okay, so boss, I'm just trying. What I know about the venturi mask is that it delivers oxygen at I think 40%. So since you are saying that we are supposed to give low oxygen for, let's say, about 1 to 2 liters, I think that could be the reason, because it delivers oxygen at 40%.
Okay. All right. I see another hand, Madam Amma. Is it Saki?
Yes. We I think we give the venturi max because the venturi max they are calibrated depending on which one you are giving. So the venturi max that I have seen are color coded. So when you pick each of them, it tells you the amount of oxygen you are giving in percentage. So when you are using the venturi max, you know that you are giving a specific amount of oxygen at a given time.
Okay. All right.
Yes.
So I think that is what you should know. Okay. The venturi mask can give an accurate oxygen you need at a given time. They can give at the accurate, okay, as compared to the rest. Okay. So the venturi mask gives or can deliver accurate volume of oxygen we need at a particular time. So if you need 1 liter, it can deliver that 1 liter accurately. That is why we use the venturi mask. Okay. So please let's take note. The retention of CO2 in COPD patient is not universal. We've established that based on the question I was asked. It's not universal. Most of them does not retain CO2. But just know that most of them, okay, are going to also get the retention of CO2. And then hence, we give them low oxygen at a given time. And then 4, infection prevention, the management. We are still on the management. Pneumococcal and influenza vaccination. Okay, because a patient with COPD is going to have mucus production, their lungs going to be inflamed. It can cause like pneumonia and influenza often. So we encourage them to do what? To take their pneumococcal and influenza vaccinations all the time. Okay, we encourage them to take the pneumococcal and influenza vaccinations all the time because they are very, very liable to get those conditions like pneumonia and cold due to the consistent inflammations in the airway. Very good. Then 5, in exaggerations or exacerbations, okay, in COPD exacerbations, intubation and BiPAP is needed. Okay, intubations and BiPAP is needed. So sometimes the airway becomes very, very narrow to the point that it is nearing what or respiratory failure is imminent. Okay, the airway has become very, very narrow to the point that what do you call it? Has respiratory failure is what is imminent. So in that instance, please, we have to intubate the patient. Okay, we intubate the patient to prevent respiratory failure, or we engage what we call the BiPAP. I'm sure you all know what the BiPAP, the full meaning is bi-level positive airway pressure. Okay, bi-level positive airway pressure. What it does is that it delivers oxygen and takes out carbon dioxide. So we place you on the BiPAP to help with that effect, because at that point in time the lung is not achieving that. Okay, so that device will help us taking putting oxygen and take out what carbon dioxide. So in severe instances, please, we can intubate or engage in what, or rely on the BiPAP to help us. Okay. Then 6, teach the patient effective airway clearance. Examples, they have coughing and then the paired sleep breathing. Okay, Madam Regina. Madam Regina, yes. You can speak. Oh, it's a mistake. Okay, all right. All right. So we teach the patient effective airway clearance, okay, like half coughing and then paired sleep breathing. Please, these are 2 key things you should know for NCLEX. The half coughing, the paired sleep breathing. You can read the question and they'll ask you how it is done. It helps to bring the mucus out because it's an effective airway clearance techniques. Okay, they are effective airway clearance techniques. So please, you should know them. I will explain how it is done shortly. Okay, so let's talk about the half coughing, or how you pronounce it, either hoof coughing or half coughing, depending on where you completed SHS or primary school. Okay, so hoof coughing or half coughing, any of them goes. So now with the half coughing, this is what you do. This is what you instruct the patient to do. Please take note. They sit upright in a chair, with their feet and their shoulders spread out. You get it? They will sit upright in the chair. Okay, let me see. They will sit upright in the chair and with their shoulders spread out, and then their feet also spread out, and then they lean forward. They will lean what? They will lean forward. Now, they will take in a slow, deep inhalation with their mouth using what? Their diaphragm. Please take note. When they sit upright, they lean forward and they take in the deep breath. Okay. Now, they will hold their breath. This is where I like. Please take note. They will hold their breath for at least 3 seconds. So between 2 to 3 seconds, they can hold their breath. Okay. So they will hold their breath for at least 2 to 3 seconds. And then after that, they will forcefully exhale. Underline word, forcefully exhale. Okay. They will forcefully exhale. Hold your breath for 2 to 3 seconds and forcefully exhale. Now, please take note. Another point, key one. You are going to repeat this huffing once or twice more while you refrain from performing a normal cough. So please take note. This is how they will do the coughing. They are not going to cough like, no. They are mentioning the word who. Just know that. They meant the word who, W-H-O. Who, okay? So when they take in the deep breath and they hold it for that seconds, then they'll do like this. Who, okay? They will do who without coughing like, no. When they cough forcefully at that point in time, it can decrease their respiratory drive. So they refrain from coughing at that moment, okay? So they will do the word who. So who to bring the mucus out. And then we say that they are going to repeat this for like 5 to 10 normal breaths as necessary to bring the mucus out. Are we getting it? They sit upright. They will inhale deeply through their mouth, okay? And then hold their breath for 2 to 3 seconds, and then exhale forcefully, making the who sound. Refraining from normal coughing. This is what we call the hoof or the half coughing. Now, the indication or the idea behind this half coughing is to bring the mucus out. The idea behind this half coughing is to bring the mucus out. So when you get this question on the NCLEX, what is the indication behind a half coughing? Please note, to bring the mucus out. To bring the mucus out. To bring the mucus out. Okay? To bring the mucus out. Now, on pursed lip breathing, that one too, how do you do it? This I'm going to also do that one. In fact, I've seen a question on this one. And then you should focus on the seconds here too, the seconds more. So this one too, the patient will sit upright. Will sit upright, everything. Spread the shoulders and all the stuff. Now, this is what they do. They breathe slowly through their nose. They breathe slowly through their nose. And they hold their breath for 2 seconds, or by counting 1 and 2. 1, 2. Are you getting the point? They inhale through their nose, hold their breath for at least 2 seconds, or they count 1 and 2. Okay. So let me say you are going to breathe in for 2 seconds, or you breathe in by counting 1 and 2. And then you exhale for 4 seconds. For 4 seconds through a pursed lip manner, like you are blowing a whistle. But here, like, you're not going to blow the whistle. I'm just making an example. Okay. They will not blow any whistle. But then you know how you are blowing a whistle, how you do your mouth. That is what we call the pursed lip. Okay. How you assume your mouth when you are blowing a whistle is called the pursed lip. So when you breathe in for 2 seconds, or by counting 1 and 2, you exhale for 4 seconds through your mouth by assuming that whistle nature or that pursed lip manner. Then we can also achieve the pursed lip breathing. And this is done to bring the carbon dioxide out. So please, let's get the difference. Half coughing is to bring the mucus out. Pursed lip breathing is to bring the carbon dioxide out. I'm sure we are clear. When you meet this question on the NCLEX, you are going to get it. Okay? You are going to get it. So half coughing, you breathe in deeply through your mouth. You hold for 2 to 3 seconds. You exhale forcefully by doing poo, poo. Pursed lip breathing, you sit upright. You inhale through your mouth 2 seconds, or by counting 1, 2. Then you exhale through your You inhale through your nose, so in pursed lip, okay? Through your nose for 2 seconds, or by counting 1, 2. You exhale through your mouth by assuming that whistling nature of your mouth, okay? Or the pursed lip for 4 seconds. You exhale through that for 4 seconds. The indication for pursed lip is to bring the carbon dioxide out. For half coughing, you bring the mucus out. Clear. 7, adequate hydration. Okay, adequate hydration. So ideally 2 liters a day. The reason is that when you hydrate a patient with mucus, it helps to thin the mucus. When you have too much fluid, or you stay hydrated, the water can thin the mucus and it can come out. Okay, that is why we encourage them to do what? To stay hydrated. Then 8, use a cool milk humidifier. We all know why we use humidifiers. Okay, it makes the air entering a bit warm. It reduces and can help with dilations. Are you getting it? When the air entering your nose, or let me say your mouth, are humid, it can even help dilate the airways to some point, and then reduce the narrowing. Okay, that is why. And then 9, sit upright to help with dyspnea, but tripod position and exacerbation. So if the patient COPD is under control, we encourage them to sit upright or in a high Fowler's position. So here is where most people get it correct or wrong on the NCLEX. In the question, please take note in the question. If they state COPD, what is the normal position for a patient with COPD? Please pick high Fowler's or upright position. But if they tell you a patient with COPD exacerbation, please pick tripod position. Are you getting it? Good. So if the COPD is under control, they must assume a high Fowler position or upright to help expand the lungs. But in an instance where there's an emergency, exaggeration, exacerbation, okay, they must what? Pick tripod. I said that on your NCLEX, if they give you the question, a patient with COPD alone, a patient with COPD, what is the right position you put them? Please, high Fowler or upright position. Okay. But the moment you see a patient with COPD exaggeration or exacerbation, please pick tripod position. That is the only way they can breathe. In severe instances or in emergencies or in exaggerations, they can only breathe when they assume that tripod position, not in the upright. But when you have given your bronchodilators, your corticosteroids, and everything under control, Patient is now under control. We don't really need the tripod position. So now we can now put them in an upright or a high flat position to help with their breathing. Okay, all right. So that is that for some nursing management with the patient with COPD. Now let's talk about their diet. So 1, drink water between meals, but not with meals. Okay, drink water between meals, but not with meals. Drink water between meals, but not with meals. Here to sometimes it confuses people. When we say drink water between meals, it doesn't mean that, for example, if you are eating rice, you tear 1 spoon, you drink water, and you tear another one. That doesn't mean you are drinking water between meals. No. Maybe you tear one spoon, you drink water, and then you tear another one. People think that one is between meals. No. That one is not drinking water between meals. No. Okay, that one is not drinking water between meals. Drinking water between meals means that you give your time, let's say 30 minutes, you finish eating, and you wait for a while, another 30 minutes before you can drink water, before your next meal. For example, you took your breakfast between 7 to 9, you took your breakfast. Please wait a bit. So you finish eating like, let's say 8 o'clock. You can wait for like 45 minutes before you drink water. This is what you mean by drinking water between meals. And then your next meal will maybe the lunch. Okay. But when you take 1 spoon of rice and you drink water and you add another spoon of rice, this is what? Drinking water with meals. Okay. You drink the water whilst you are eating. So this is what drinking water with meals. And it's not good for a patient with COPD. Do you know why? A patient with COPD lacks energy, low oxygen. They are experiencing fatigue. So why do you want to burden that patient? Why are you going to burden that patient with too much at a time? So why don't you let them eat fast so that they can have enough time later to drink the water? But you are drinking in water, bringing in food, bringing in water. You are going to burden them. Okay, you are going to burden them. They will not even have the energy to stay for long with that routine. They are eating the food and drinking water at the same time. So that is why they drink water between meals, but not with meals. In the patient with COPD, we don't want to increase the oxygen demand. Already the oxygen is low. So to prevent the oxygen demand, please give the water between meals and not with meals. Then 2, small frequent meals at a given time. Small frequent meals. Don't give them large meals. Again, they don't have the energy to sit behind food to eat for that longer period of time. They don't. Okay, they don't. So small frequent meals. But then please note, because it is small frequent meals, make sure that the meal is high in calories and protein all the time. They have weight loss, they don't have the energy to eat, so they eat more and they stop. So because of that, make sure the food they are eating is high in calories and in protein at all times. Then lastly, they must avoid gas-forming food. They must avoid gas-forming food. They must avoid gas. Who can tell us why they must avoid gas-forming foods? Yes, COPD patients. Why? Yes, why? Please raise your hand. Say it, I'll give you a lewa. Me, I like saying a lewa, pa. Okay, Madam Ama Saki.
I think that it's because you don't want them to get so bloated because already they need to take they always want to have to expand their lungs so that they can take in air. So you don't want, when they get bloated, their capacity to take in oxygen is going to be reduced, maybe.
Perfectly. Perfectly. Okay. Yes, Madam Tina, I want to hear you too. Madam Tina, yes. Mr. Karim, I know if I want to hear you too.
Yeah, so what I wanted to say is just in line with what the sister said. So I wanted to say that it will increase the intra-abdominal pressure, and then so that will reduce the lung from expansion.
That is all. Okay, that is all. So you don't give them beans, broccoli, cauliflower. Okay. So having said that, please try and know them. Examples of food that cause what? Gas. Because on the enclaves, you might see them. A patient with COPD was admitted to your ward. Which of the following foods should you not encourage the patient to eat? Please, beans, cauliflower. This food can increase gas. When there's increase in abdominal pressure, mind you, already the diaphragm has been flattened. It's not really expanding. So why do you want to even increase the lungs not even expand at all. Okay, so don't give them gas forming food. And even this is the reason why you shouldn't also let them drink water, drink water and food at the same time. Imagine eating and drinking water at the same time. What happens? You become full very, very easily. And this can also increase the size of the stomach, and it will not help the diaphragm to also relax or contract. You getting me? And then also interfere with oxygenation. So please let's take note. Their diet, drink water between meals, not with meals, small frequent meals, but high calories, high protein, avoid gas forming foods. Okay? All right, perfect. Let's move on. Okay, yes, Madam Amasaki, you want something? You want to say something? Or is the old hand? Okay, I think it's the old hand, right? Okay, let's move ahead. Now, pharmacological treatment. Please, are you on course? Are you really following? Or you are tired already? Are you following? Okay, I'm sure we are all following, right? Good. So, the management of COPD, pharmacological management, bronchodilators. Usually, we give bronchodilators first. Okay, so we have albuterol, ipratropium. Okay, albuterol, what? Ipratropium. Now, please, let's listen. Here too, we have some English tips here. Okay, as I mentioned them, you can note them down, or you must pay attention. Okay. So albuterol is a bronchodilator. In fact, it's a short-acting bronchodilator. Okay, albuterol is a short-acting bronchodilator. You can say SABA. SABA OMO for what's it? Okay, SABA. Now, once you hear SABA, think what? Short-acting beta agonist. Okay, short-acting beta agonist is a bronchodilator. Okay, short-acting beta agonist, SABA. Okay, an example is the albuterol. What does albuterol do? It dilates the airways. Okay, it dilates the airways. Albuterol dilates the airways so that air can now enter. You know, in COPD, there is mucus production blocking the passage of air. Okay, blocking the passage of air. So we need something to dilate it to allow air to enter. So we can give them the albuterol. Now, mind you, when you give albuterol, albuterol will dilate the airway. Okay, dilate the airway. But let's take this into consideration, the English tip here. So one, you know that albuterol dilates the airway, right? And then what does albuterol also do? It causes what? Insomnia, palpitations from tachycardia, and then tremor. Okay? Insomnia, palpitations, and what? Like from tachycardia and tremor. So please, if a patient takes albuterol, okay, and then they have palpitations, I can say it's an expected finding because it is a side effect of the drug. So usually patients who take albuterol for conditions like asthma and conditions like COPD get this side effect, which is what? The palpitations, tachycardias, and then the tremor. So please, let's take note. Someone is asking whether albuterol is the same as salbutamol. Yes, it's the same. Okay, so you should know that there are just different name for, for like, let me say, same ingredient or same drug. Okay, there are different names for the same drug. Just that the albuterol is usually used in the US, okay, by other international bodies, and they say salbutamol. Okay, they say salbutamol. So it's the same, okay, it's the same. So salbutamol usually in other countries, but albuterol in what? In US, okay. So please, because we are going to US, let's say albuterol, not salbutamol. Let's practice from now on, okay. All right, so that is fine. And then the next drug we give is the ipratropium. Who can tell me the class of drug ipratropium falls under? Though it has that bronchodilators properties. Yes, it falls under which class of drug? Ipratropium.
But I think it is in Nepal. I don't know how to even pronounce it, but it starts with M something.
I don't know that one. But I'm patient. Yes. But I'm patient. Oh, this one I want to say. Okay, anticholinergic. Okay, please, the one with the name iPhone. I couldn't know how to call you, but I can't call you iPhone. So if possible, please change your name to your original name. Okay, I can't address you iPhone. Okay. All right. So it's an anticholinergic. Okay. It's an anticholinergic. You get it? It's an anticholinergic. Okay. It's an anticholinergic. So please let's take note. It's an anticholinergic. Now, you can also give them ipratropium to help with to open up the airway. Now, anytime you're giving anticholinergic, please take note of this. They dry up secretions. I think I didn't put on my slide. It's kind of common on the ankle. So a patient with COPD was prescribed ipratropium. 3 days later, the patient complained of low urine output, dry mucus, no sweating. Please know that the ipratropium is causing that. Okay, ipratropium dry up secretion. So once you see ipratropium or anticholinergics, know that they dry up secretion. Now, how do they do this? Should I give an assignment? Ipratropium, that's what they block acetylcholine. Acetylcholine is a neurotransmitter that helps with mucus production. Okay, acetylcholine helps with what? With mucus production. But ipratropium or anticholinergics blocks this acetylcholine, so they can't now produce the mucus. That is why they get low sweating, low urine output, low tears. Okay, so that is what we mean by what anticholinergics, or you expect for anticholinergics, and then ipratropium. Okay, that is that. Then 2, we have corticosteroids. So we give the corticosteroids for inflammation. So the ipratropium, the albuterol is for what? For dilation, bronchodilations. The corticosteroid is for what? Is for what? Inflammation. Example is the methylprednisolone. Please, on your ankles, when you are giving steroid, you must remember the 8S. Can we start mentioning the 8S? Yes, the 8S. The 8S, yes. Who can say one? The 8S. So I'm saying one. One is sex. One is sex. It decreases your libido. Steroids decreases your libido. What again? Yes, Madam Sarah, yes. Yes, Madam Patience, yes, Madam Doris, yes. What again? Mr. Karim, let's speak.
Sepsis.
Sepsis, that is inflammation, right?
Yes.
Good, yes. Another S.
It's called hyperglycemia and hypertension.
Hyperglycemia, yes. Sugar, very good. Yes. What again? So there are 8, okay? There are 8. Please, let's know them. So sepsis, okay. Once again, iPhone, you are here. Please, you can talk. What would you want to say? You can speak, oh, it was a mistake. All right. So we have sepsis, We have sepsis, because steroids decrease immune system, right? We have sex, it decreases your libido, okay? We have sugar, increases sugar levels, causing glucose, okay? Yes, Madam Patience, your hand is up.
Yes, it causes soft bone.
Soft bone osteoporosis, don't forget, okay? Soft bone osteoporosis. Then sight affects your eye, sight, okay? So these and many more. You should know, Madam. Yes, Madam Abigail. Yes, what do you want to say?
The swelling, increased weight.
Weight, swelling, okay, swelling. It causes retention of water and the rest, okay, good. So please, let's know them. Let's know them. So due to this, but the common ones that they really bring on the ankles is the sepsis. So when you're taking steroids, you don't go into crowded areas. They must take the Avastin. You take into consideration what? Neutropenic precautions. No flower in their room, no sun in their womb. They must never eat an uncooked or an unwashed vegetable or fruit. Okay. Then another one is the soft bone osteoporosis. Due to this, what do you have to take into consideration? 4 risk precautions for your ankles. 4 risk precautions. What do you have to do in 4 risk precautions? Institute grab bars, okay, around. Make sure there are no throw racks on the floor. Make sure that the patient has a good eyesight, because if you can't see, you're going to fall. Okay. So periodic eye examination. So please, these and many more, you must know them for our ankles. Okay. So eyesight examination, no throw racks, non-skid soles. The patient should not wear non-skid soles. Okay. A patient should wear, rather, the patient should wear an unskilled shoes. Okay, you should wear an unskilled shoes. And then what again? What again? For forest precautions, yes. Avoid cuts. Okay, all right. So these and many more about forest you should be expecting for what? For your ankles. So that is that. Okay. Then 3, we have expectorants. Okay, expectorants. So we talk about bronchodilators to dilate the airways. We have corticosteroids to treat the inflammations in the airways. Then we have expectorants. What does expectorants do? It will help to bring the mucus out. Expectorants will help bring the mucus out. So we have what? Guaifenesin. Guaifenesin is an example of expectorants given to a patient with COPD to help bring the mucus out. Then 4, antibiotics. Okay, antibiotics. It also helps with what? To treat infections like the pneumonia, the flu that can occur due to consistent inflammations. Okay. Then 5, they must avoid cough suppressants like codeine. Why? Because this patient has mucus. They have mucus in their airway, and then the body is even trying to compensate to cough and then bring the mucus out. So why are you going to give them a cough suppressant? It's not going to help. It is going to limit the coughing, and then the mucus will be stacked. Okay. Someone is asking, can you give theophylline? You can see it on my slide, right? You get there. Okay. So you don't give them cough suppressant because cough suppressant will what? Will suppress the cough, and then it will not help bring the mucus out. So that is why you avoid cough suppressant. Then 6, avoid what? Sedatives like diazepam. It is true. When you give them sedatives, sedative will reduce what? The cough receptors or centers in the brain. Okay. And then another one is that sedative will also reduce what? The respiratory receptors and centers in the brain. Or the patients have what? Patients have a low oxygenation. So why do you want to give another drug that will reduce the respiration further? So you avoid sedatives like diazepam. Okay. Then 7, avoid non-selective beta blocker. Example, propranolol. Avoid non-selective beta blocker. Example, propranolol. So when you see on the ankles, a patient with COPD admitted to your ward, the physician has prescribed the following medications. Which of them should you clarify? Please be looking out for a non-selective beta blocker. Example, the propranolol. Okay. So why should they avoid this drug? Okay. So beta blockers. Let's go back to the name of the drug or the class. Beta blockers. Beta blockers. So we have 2 betas. Okay. We have beta 1 and beta 2. Now, when you have hypertension, it deals with the heart, and you give a beta blocker. That one is beta 1. Heart is beta 1, and lungs is beta 2. Okay, let me just make it simple. Okay, know that heart is beta 1. Okay, so beta 1 stands for heart, beta 2 stands for the lungs. Okay, when you give a non-selective beta blocker in COPD, it will block the heart and block the lungs at the same time. Why? Because it is a beta blocker and it's non-selective. It is not going to select the heart alone. It will block the heart and block the lungs at the same time because it is non-selective. Okay, so eventually, when you give a non-selective beta blocker like propranolol to a patient with COPD, eventually it's going to further cause bronchoconstriction. So don't give them a non-selective beta blocker like propranolol. But you can give them the selective one because the selective ones will attack only the heart, the beta 1, and leave the lungs alone. Okay. But when you give them the propranolol or non-selective beta blockers, they are going to worsen the case because it's going to block the heart and the lungs at the same time. Having said this, please, you have to find examples of other drugs that falls under non-selective beta blockers because you might not see propranolol, you might see others on your ankles. Okay, you may see others. So if you don't see propranolol and you see them, you can be able to what? To identify and pick the right answer. Okay, so don't give a non-selective beta blocker because it will block the lung like propranolol to a patient with COPD and even asthma because they all have bronchoconstrictions. So why are you going to give drugs like this? It will worsen the case. Then lastly, give them theophylline. Theophylline is also a kind of a bronchodilator. It can also help open the airway. Okay, theophylline is a bronchodilator which can also help open the airway. Now, what should you know about theophylline for your ankles? 1, a therapeutic range, 10 to 20 microgram per ml. Oh, ACE inhibitors can be given, okay? Like the lisinopril and the rest, they can be given, okay? They are not really a contraindication in COPD, okay? They can be given. Even the beta blockers, they can be given. Oh, please note, the beta blockers can be given except a non-selective beta blocker. So let's get it right, okay? Okay, So theophylline has that effect to help relax the muscles, okay? Except that effect to help relax the muscles and open the airway, okay? So please, let's take note of that. Yes, you can give mucolytics. Mucolytics can be given. They all help to do what? Bring out the mucus. Mucolytics, let me say, I'll attach it to expectorants, okay? Mucolytics can be attached to expectorants. Are you here? Yes. Mucolytics can be attached to what? Expectorants, okay? They all help bring the mucus out. Okay, so we give them theophylline. Theophylline also help in some way to open up the airway to help with what? To help with air entering the lungs and air coming out. So what should you know for your ankles? 1, the therapeutic range is 10 to 20 microgram per ml. The therapeutic range, 10 to 20 microgram per ml. Then what does it do? It increases digoxin toxicity. So don't give theophylline with digoxin. Are we here? Theophylline increases digoxin toxicity. Okay. Theophylline increases digoxin toxicity. So don't give theophylline with digoxin. Do you know how it does? Okay. When we talk about digoxin, I'm asking a question. When we talk about digoxin, what electrolyte comes into mind? What electrolyte comes to mind when we talk about digoxin? Yes. Yes, when I'm a big girl.
Potassium.
All right, potassium. High or low? High or low? In this case, high or low will cause the toxicity. High or low? Yeah, Mr. Yusuf. Yeah. High or low will cause the toxicity. When we talk about lithium and potassium, which of them will cause the toxicity? High or low will cause the lithium toxicity? Which of them? Yes, Madam Patience.
Okay, so low sodium will cause lithium toxicity and low potassium will cause digoxin toxicity.
Okay, all right. So we are on potassium. Okay, so low potassium will cause digoxin toxicity. Now, do you know what this theophylline does? That given the reason why you shouldn't give it digoxin, theophylline decreases the amount of potassium in your blood. Okay, theophylline, it decreases the amount of potassium in your blood. So when you give theophylline and digoxin at the same time, theophylline will decrease your potassium, and then potassium low levels will potentiate digoxin toxicity. Okay, the reason why you shouldn't give theophylline and digoxin at the same time, digoxin will go into toxicity when there is low potassium, and then theophylline will cause low potassium. Hence, don't give them together, because when you give them, it will cause the low potassium, and the low potassium will further cause digoxin toxicity. Okay. Then lastly, for lithium, you don't give theophylline with lithium because it decreases the effectiveness of the lithium. How? Theophylline increases the excretion of lithium by the kidneys. Okay, theophylline increases the effectiveness of the lithium by causing excretion. Okay, so if a patient have bipolar and you prescribe lithium, don't give theophylline, otherwise the lithium will not work. It will cause a faster excretion of the lithium. So this is what you should know when it comes to pharmacological management for what? For COPD. Okay, please, you should know them. I see a hand up. Let me see. Madam Linda, yes, please, you can talk.
Yes, boss, please, I wanted to know about the lithium. What does it do?
It's lithium actually helps with mood stabilization. Okay, let me see. Lithium is a mood stabilizer. Okay, it doesn't really play any role in the COPD, but I'm just saying that you should know something for theophylline with your ankles, so that when you see them, you can answer. So, for example, we meet a question like a patient with COPD was prescribed theophylline to help with the airway. Which of the following drugs should you clarify? For example, lithium. It will not. It will not going to let the lithium work very, very well. Or a patient with lithium, bipolar disorder was prescribed lithium to help stabilize the mood. Which of the following drugs should you clarify? Clarify theophylline, because theophylline will decrease the effectiveness of the lithium. Okay. And there may be a question like a patient was prescribed lithium and then theophylline at the same time, but we didn't get the effect, or the effect of the lithium is not being achieved. What should you do? Hold the theophylline. Okay, you have to hold the theophylline, because when you give them together, the theophylline is not going to help with the effectiveness of the lithium. You have to hold the theophylline. Okay, all right, so that is that. All right, so this is what you should know when it comes to pharmacological management of what? Of COPD. Okay, all right. Please, any question before we talk about the complications? Any question so far? All right. Then let's talk about the last thing under COPD. Complications. Complications. Okay. Complications. So one, respiratory failure. So COPD can lead to respiratory failure, which can be life-threatening. Of course, there's no time to waste here. Okay. There's no time to waste here. If you have COPD, there's low amount of oxygen entering the lungs, low amount coming out, hyperinflation, the lungs is not expanding. If care is not taken, respiratory failure will set in. It's as simple as that. Okay, then two, pneumonia. Patient with COPD are at higher risk for developing what? Pneumonia. Of course. Okay, because pneumonia is going to occur because there's increase in mucus production, increase in inflammations. This will affect the lungs as a whole, and it can cause what? Pneumonia. Okay. Then the last two complications is what I'm going to explain. Okay, so please, let's pay attention here also. I'm sure you've been seeing it all the time, called pulmonary or heart failure, especially right-sided heart failure. It's a complication of COPD, okay? Right-sided heart failure or called pulmonary, okay? I don't know how you pronounce this word anyway, but I say it called pulmonary, okay? Maybe you can say it called pulmonary, how or where you completed SHS, okay? Or your primary school. The madam who taught you the English, maybe, I don't know. Okay, so I say it called pulmonary. All right. How does a patient with COPD end up with right-sided heart failure and a called pulmonary? Okay. How does a patient with COPD ends up with heart failure or called pulmonary? Okay. All right. So let me explain. Good. In COPD, what is occurring? A damage to the lungs, primarily. Damage to the lungs. Air is not entering the lungs. Air is not really coming out. Okay. So there is damage to the lungs in COPD. Now, let's go back to circulation. When blood is flowing from the inferior vena cavus and the superior vena cavus, it enters where? The right atrium, right? Am I right? To the right atrium, through the tricuspid valve, to the right ventricle. Am I right? Yes. To the right atrium, through the tricuspid valve, to the right ventricle, okay? Then from the right ventricle, deoxygenated blood leaves there through the pulmonary artery to the lungs. Now let's dwell here. Here is where the problem is, okay? Here is where the problem is. The blood is deoxygenated through where? The pulmonary artery to the lungs. Now, here lies the case the lung is having a problem. The lung is having a problem. Limited oxygen, mucus productions, air cells has lost its elasticity, so there's problem with the lungs. So the deoxygenated blood cannot go into the lungs for us to get oxygenated blood for the rest of the body. Are you getting the picture? The blood coming from the right side of the heart are deoxygenated or is deoxygenated. We need them into the lungs for them to be oxygenated so that the body can use it. Here lies the case that amount of blood and oxygen is not entering the lungs for us to get the oxygenation. So the body begins to starve with oxygen. Key organs like the kidney, the brain, the liver will not get enough oxygen. So what do you think the body will do? Compensatory mechanism will set in here too. The body will try to compensate. How? By increasing the blood flow through this pulmonary artery to the lungs. Okay, they will begin to increase the blood. Charlie, please, the air is not going on. So this is how the body will say, can't you see the air is not going through the pulmonary artery to the lungs for us to get oxygenation? The kidney is suffering. The brain is suffering. It doesn't get the oxygen. What are you waiting for? Please increase the blood flow. Increase the red blood cells. Increase them. So that increase will cause pressure in the pulmonary artery, leading to what we call pulmonary hypertension. Okay? That increase, that pressure, that compensatory mechanism to force the blood and the oxygen to the lungs, will cause an increase in the pulmonary artery, leading to pulmonary hypertension. Now, the moment pulmonary hypertension sets in, blood flow through the pulmonary artery is blocked or is narrowed or is impeded, then blood begins to backflow into the right side of the heart, leading to right-sided heart failure or call pulmonary. Are we getting it? I'm sure the explanation, I'm sure you've gotten it. Okay. So low amount of oxygen, low amount of oxygen, entering where? Low amount of oxygen entering the lungs. Okay. Low amount of oxygen entering the lungs at a given time. So the kidney, Charlie, the kidney, I'm suffering. I'm not getting oxygen. The brain, and you know, when there's low amount of oxygen going to the brain begins to get confused. So please, I need the oxygen. I need the oxygen. The brain, the body will start to compensate. Charlie, let me force the blood. Let me force the blood to the lungs so I can get oxygenation. Let me force the blood. Let me force the oxygen. And we all know that containing red blood cell is what? Hemoglobin. That carries the oxygen. You get it? So let me force the blood to the lungs. Let me force it there. Let me force it there. So that forceful nature will begin to increase pressure in the pulmonary artery, leading to what? Pulmonary hypertension. The moment pulmonary hypertension sets in, blood flow will not go that much, causing a backflow of blood to the right-sided heart, and it's going to cause what? Right-sided heart failure or call pulmonary. This same idea will cause polycythemia because when the oxygen is not going, the body increases the red blood cell productions. Okay, in an attempt to force the blood or to increase the oxygen carrying capacity, there's increase in red blood cell production because I want to force the blood. I want to force the oxygen. I want to force it. Why don't I produce more? In that attempt, the body begins to produce more red blood cells. Okay, to get more hemoglobin. The body begins to produce more red blood cells. At a point in time, because there's more red blood cells, the blood becomes very, 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 very thick. Okay, the blood becomes very, very, very thick. Hence, you are getting what? Polycythemia. Okay, viscosity of the blood, polycythemia, due to the body's ability to produce more red blood cells to force itself. It causes what? Viscosity of the blood, and you can get polycythemia. Okay, so do you think or don't you think COPD can cause stroke or CVA? Because at the point in time, if there is viscosity of the blood or there is increase in red blood cells and the blood stays at the point of, it stays or there's increase in viscosity, it contributes to what? Blood pooling. Okay, when there's increase in blood or there's increase in the viscosity of the blood becomes very, very thick. It can eventually become what? Put at one place, or they begin to cause venous stasis. Venous stasis will begin to cause what? Clot formation, because increase in red blood cells, then the blood becomes to pool at one side. Venous stasis now lead to what? Clot formation, because the blood is staying at one side. Hence, if there's displacement of the clot, it can cause what? Stroke. So you see, COPD can lead to what? Can lead to stroke. Okay, so please let's take note. But it's very, very rare. Okay, in as much as can occur, it's very, very, unless it's a severe instance, it's very, very rare. Okay, so that is that for the complications of COPD. Okay. Yes, Madam Sarah.
Yeah, so I was going to ask that by then the patient is already dead before they will get to the
stroke. Yeah, because it's very, very rare. Okay, hardly will you get COPD to get stroke. Okay, but it can occur due to this analogy or this idea. when the blood becomes very, very thick, because there's increase in red blood cell production, the blood becomes thick, clots can form, okay, like what we see in atrial fibrillation, okay, when the heart does not pump the blood and the blood stays there for long, venous stages, okay, clots will form, okay, so the same thing, increase in red blood cell for production causes venous stasis, clots begin to form, it can lead to CVA, okay, all right, yes, Madam Sarah.
So would the same problem cause portal hypertension? The
Portal
back
hypertension is,
will
it
it
can,
be causing that?
it can, but it's not really rare. I mean, portal hypertension has to do with liver cirrhosis, okay?
Okay.
It has to do with liver cirrhosis. When, you know, the portal vein is through which blood leads to the liver, okay?
Okay.
It is through the portal vein that blood leads to the liver. So when the liver becomes a host, the blood begins to backflow in the liver and it can cause portal hypertension, okay, through the portal vein. Are you getting it?
Yes.
Yes. All right. And I'm not, what are you saying? What exactly fails? Is it the overworking of the right ventricles? Because no, usually what fails in the causing the right side heart failure is the pulmonary hypertension. So when there's increase in the red blood cell production, when there's increase in the red blood cells causing the forceful nature of the blood through the pulmonary artery, it causes pulmonary hypertension. So the pulmonary artery begin to receive tensions. So the failure begins the pulmonary artery. So there's pulmonary hypertension. And because of that, if you have hypertension, what do we mean? The blood is not really flowing. There's hypertension. There's, I mean, some kind of narrowing, okay? The blood is not really flowing through the artery. This will cause a backflow. So when the blood begins to stay there, it's going to cause failure of the right side of the heart, okay? That is why they are getting the right side of the heart failure. All right. Yes, Mr. Foster.
Please, can it also cause cystic fibrosis?
Cystic fibrosis. Cystic fibrosis is something. No. Okay, it's not common. COPD, fibrosis. Well, okay, we may say that because of the mucus production. Okay, because in cystic fibrosis too, we have mucus productions. Okay, but that one is secondary to something. Cystic fibrosis and the mucus production is secondary to something because there is a defective chloride channel. Okay, there is we will get there. Cystic fibrosis is part of our slide. Okay, I brought it in, though it is an pediatrics, but because it's common with ankles, I chipped it inside our slides. Okay, to talk about it. Okay, there is something wrong with the chloride channels. Okay, and this is causing mucus to being overproduced, leading to what? Leading to the cystic fibrosis. Okay, so there's a connection between COPD and cystic fibrosis, but then cystic fibrosis is when there is actually the defectiveness of the chloride channel. Okay, so that is something you should know. And as someone is saying, cystic fibrosis is inherited. Okay, both parents must carry a gene to cause cystic fibrosis. Okay, both parents must carry a gene. That is what we say that it is autosomal recessive. Okay, we will get there. Okay, don't worry. All right, so that is that for COPD. Yes, any further question? Okay. Any further question? Okay. Any further question? Yes, of course. Cystic fibrosis can lead to COPD. If you are saying it in that way, that is fine. Cystic fibrosis can now lead to COPD because cystic fibrosis, the mucus production. So that mucus production can further cause the COPD because when you have mucus production, COPD, we say that there's mucus production. Okay. But the other way around, it will be difficult. But when you have cystic fibrosis, you can get COPD because of the mucus productions. Okay. Yes. All right. Yes. Any other question, please? Any other question? Do you have any question to ask on COPD? Because we bring the curtain down here. Any question to ask on COPD? Or we are okay? We are okay. Are we okay? COPD, are we okay? COPD, are we okay? All right. I think we are okay. and there's no question to ask, right? I see a hand up. Madam Linda. Yes, Linda.
Yeah,
Please.
please, I wanted you to move back to the signs and symptoms for me.
Oh, okay.
Yes, please.
It's here. Okay, it's here. Any question here, or you just want to see it? All right. So these are the signs and symptoms. Okay.
Okay, thank you.
All right. So since we are okay, I have some questions on my slide as I always do. So please, let's solve them. Okay. All right. Let's move ahead. Let's test our knowledge on COPD and see if we are there. Okay. All right. Can someone read, please? Let's solve them before we close. Can someone read for us? Who will read? Raise your hand. Let me unmute you, and then you can speak. Who will do as the honors? Who will read for us? Okay, Madam Esther. Madam Esther, please read. Okay. Kindly read.
Okay. So the nurse teaches a client with COPD to assess for signs and symptoms of right-sided heart failure. Which of the following signs and symptoms would be included in the teaching plan? A. Clubbing of the nail bed, hypertension, peripheral edema, and D. Increased appetite.
Okay, so what are you picking? Yes, Madam Mary. Yes, Madam Mary. Madam Mary, please unmute. Madam Abigail, you can speak.
Thank you very much. I'll go for A, clubbing of the nail beds.
Hey, are you sure? Okay,
Which
why?
of the following would be included in the teaching?
Mm-hmm.
They say the nurse teaches a client with COPD to assess for signs and symptoms of right side. Right side. No.
You see. What are you going for now? What are you going for now?
Okay, if it's right side, we talk of the peripheral edema is there.
Okay. All right. Okay. So please, sometimes we have to be very, very vigilant on the enclaves. These are some of the reasons why we sometimes make mistakes and select wrong answers. You may know the content. Trust me, you may know the content. You have the content, but sometimes just emitting a common, you get them wrong. You get it wrong. Okay? Just emitting the common or the key word. Okay. So please, let's try as much as possible to read a question well before you pick the answer. Okay. So of course, right-sided heart failure, the answer is C. Okay. All right. So rationale. Right-sided heart failure is a complication of COPD that occurs because of what? Pulmonary hypertension, as I explained. Signs and symptoms of heart failure include pulmonary peripheral edema, jugular vein distension, hepatomegaly. Okay. So the person who had the question about the portal vein hypertension. Okay. When there's right-sided heart failure and the hepatomegaly, okay, it can further cause what? That portal hypertension. Okay, maybe in those, it's a long process. Okay, if it is family, we will say a long family. Okay, and then weight gain. Okay, weight gain due to increased fluid volume. Clubbing of nail beds is associated with conditions of chronic hypoxia. Okay, of course, it can be seen in COPD, but it's not really a common sign. Okay, then hypertension associated with what? Left-sided heart failure. Client with heart failure has decreased appetite. But you know the common answer here, it should be C. Okay, it should be C. Okay, all right. Yes, Madam Esther, please, you can read. Madam Esther, are you there? Or you can't unmute. Raise your hand, I'll unmute you. You raise your hand and let me see if I can unmute. So please, can you read?
Okay. So the nurse is planning to teach a client with COPD how to cough effectively. Which of the following instructions should be included? A. Take 3 deep abdominal breaths, bend forward, and cough while saying "who" on exhalation.
B. Lie flat on back, splints the thorax, take 2 deep breaths and cough. C. Take several rapid shallow breaths and then cough forcefully. D. Assume a side-lying position, extend arm over the head, and alternate deep breathing with coughing.
Okay. There's some confusion here. I'm seeing A and then I'm seeing C. Okay, let's see who wins. Okay, I'm seeing A, I'm seeing C. And I know most people are picking the A because I said who, right? All right, all right, all right, all right. So, but please, why are you picking C? Those picking C, why? Why are you picking C? Why are you picking C? Why are you picking C? Those picking C, why are you picking C? The rationale, shallow breath. Are you going to take shallow breath or deep breath? The option C, take several rapid shallow. Is it shallow or deep? It should be a deep breath. Okay, it should be a deep breath. So don't be tricked. Then option B, why should you lie flat on your back? You have COPD. You should be sitting upright for lung expansion. You should be sitting upright for lung expansion. And you are lying down. How can you expand the lung? Then the last option, option D, assume a side lining, extend the arm over the head, and alternate deep breathing with coughing. No, you shouldn't be lying on your side. It should be upright. Okay, so here the right answer is the option A. Okay. All right. So let's read the rationale. So the goal of effective coughing is to conserve energy, facilitate removal of secretions, and minimize airway collapse. The client should assume a sitting position, sitting, upright, sitting, with the feet on the floor if possible. The client should bend forward slightly and using pursed lip breathing, exhale. Okay. After resuming an upright position, the client should use abdominal breathing to slowly and deeply. Okay. So let me go back to the option C. You see, they interchanged it. Have you seen it? They interchanged it. They say rapid shallow breath. It should rather be slowly or slow deep breath rather, not rapid shallow breath. So don't be tricked. Okay. So you take in a deep abdominal breath, bend forward, and then you cough while saying the word who, WHO. I demonstrated this. Okay. I was expecting all of us to pick even the A. Right. This intervention is called the half cough. Okay. It's called the half coughing. All right. So lying flat does not enhance lung expansion. Why should you lie flat? Sitting upright promotes full lung expansion of the thorax. Okay. So shallow breathing does not facilitate removal of the secretion, sorry. And forceful coughing promotes what? Collapse of the airways. So please here, don't get me wrong or don't get the rationale wrong. Forceful coughing. What did I say when I was explaining the half coughing? You just do who or who without coughing like no. It can collapse the airway. So you just keep the word in your mind. WHO who. So when you take in the deep breath and you are exhaling, you are just doing who. You are not coughing, okay? Because when you cough at that point in time, it can what? Cause airway collapse. Please take note of that. All right. A side lining position does not allow for adequate chest expansion to promote deep breathing. All right, clear. Yes. Next question. Madam Esther, kindly.
Okay. So the nurse who is explaining the pathophysiology of COPD to a client includes the fact that alveoli distraction results in which manifestation? Select all that apply. A. Decreased surface area for gas exchange. B. Increased dead space air. C. Development of pulmonary emboli. D. Chronic dilation of the bronchioles. E. Airway collapse related to loss of elasticity.
Very good. Please here, don't get tricked. Don't get tricked here. All right, let's pick the answer. Yes, let's pick the answer. Yeah, someone said DEA. What again? Someone picked D because the person saw pathophysiology of COPD, but ignored the fact that there's alveolar distraction result. The question was centered on alveolar distraction. Alveolar. Please read questions well. It's very, very key. The next, who is explaining the pathophysiology includes the fact that alveolar distraction result in which alveolar, be specific, alveolar. Okay, alveolar. All right, let's see the rationale. So the answer is AE. Okay, AE. Okay, AE. All right. So the loss of elasticity in the airway of the client with COPD can be airway attributed to repeated infections and inflammations, okay, which leads to airway collapse. Airway collapse can cause alveolar distraction because of either over or under inflation of the alveolar sacs, okay. The impaired gaseous exchange occurring with COPD is caused by loss of what? Alveolar surface area available for gaseous exchange. Distraction of alveoli is not related to increased dead space, pulmonary emboli, or chronic dilation of the what? Of the bronchioles, okay. So the air sacs are being damaged, not allowing enough gaseous exchange, okay. So don't pick the D because the question was centered on alveolar distraction, okay. All right, that's fine. Okay, please, next question. Okay, please, I think there's a hand up. Madam, Patience, yes, please talk. Please talk, yes, you can talk.
Can I please feature this question?
You want to picture the question?
Yes.
Okay, it's here. The question is here. Okay, all right,
Okay.
that is fine. Okay, all right. Please, next question, please, you can read, Madam Esther.
Okay. Yes. So, what should the nurse include when teaching health maintenance strategies to the clients with COPD? Select all that apply. 1. A. Yearly influenza immunization. B. Immunizations against pneumonia. C. Limitations of physical activity. D. Oral fluid restriction. And then E. Adequate caloric intake.
Okay, Sata, yes, let's go. A, B. Good. Don't get strict. C, the option C. Don't get strict. Okay, so I'm seeing A, B, E, A, B, C. Okay, so let's go through. So the options, A, B, A, B, C, A, B, A, B, C, A, B, A, B, C. All right. So the nurse is educating a patient with COPD about maintenance strategy. What should you do? So yearly influenza immunization. I think I said it to prevent what? Flu and those. So that one is correct. B, immunization against pneumonia. Of course, I said it. Pneumococcal vaccine should be taken, right? So let's say AB. We are picking AB now. Then let me even skip the C. I will come to the C. Let me skip the C. D, oral fluid restriction. Why should you restrict fluid? You don't have to. We need fluid to thin mucus. Okay, so that one is out because we need fluid to thin the mucus. Then E, adequate caloric intake. Of course, I said it. High calories, high protein because they eat in small or in bit by bit. Okay, they eat in bits. So the small amount they are going to eat, it should be high in calorie to prevent malnutrition and weight loss. Now let me come back to the C. Do you think, first of all, the option said limitation of physical activity. Physical activity could mean rising up from bed, just rising up from bed. Do you think if you have COPD, you can't do physical activity? When you move from your bed to, let's say, your mirror, it's a physical activity. Can't you do that? Now, let me just assume you read into the question, which is not good for your ankles. But let me just assume you read into the question and then you assume exercise. Okay, you assume because the difference between exercise and physical activity. If I raise my hand, it's a physical activity. if I raise my legs, the physical activity is different from exercise. Okay. So let me just imagine that you ready to the question and then you pick or you assume physical activity to be exercise. Do you think that a patient with COPD shouldn't exercise? So let me explain. The fact that COPD patient has limited oxygen does not mean they shouldn't exercise. Exercise is good for the entire well-being of the body. Okay, we need exercise to do what? To help with peristaltic movement. We need exercise to prevent DVT because immobility will cause venous stasis and can cause what? Can cause DVT. So we really need exercise. It helps the general body. So to prevent the increase in oxygen demand or shortness of breath with this patient, to prevent it with this patient, what should you do? It is better that you give them drugs like bronchodilators before they exercise. The bronchodilator will open the airway so that when they exercise or when they perform the physical activity, air can enter. Okay, air can enter. Are you getting the point? Because they will get tired if they exercise along the line. It is important that you let them take a bronchodilator to open the airway before they can exercise, so that in the course of the physical activity, they don't go into hypoxia. Okay, that is why I'm thinking that C is wrong. Okay, if you pick C, are you getting the point? But let's see the rationale and let's see if C is bad or we are those who pick the A, B are wrong and they didn't bring the C. Let's see the rationale. Good. So the option is A, B. So let's see the rationale. Okay. Client with COPD has or are high susceptible to respiratory infections such as influenza. So they should be immunized or yearly. Client with COPD use a large amount of calories because of labored respiratory function. Increased caloric intake is necessary to maintain a healthy weight. Don't forget, client with COPD should undergo a progressive rehabilitation program to increase their activity tolerance. Okay, there's no way you can say the patient has COPD and maybe when they perform physical activity or exercise, they go into hypoxia, so they shouldn't exercise. No, exercise is good because it's helped with other areas, peristalsis and the rest. Okay, so they must go into what? Rehabilitation program. I think I said it, right? Rehabilitation program to increase their activity threshold. Then lastly, fluid restriction is not intended with COPD unless there is a fluid retention from another etiology, like what? Heart failure. If COPD patients get heart failure, don't give them fluid. In as much as we need fluid in COPD to thin the mucus, never give it if they have heart failure, because in heart failure there is edema. We have to restrict fluid. Don't get tricked. Perfect. All right. Maybe this is our last question. Madam Esther, can you read?
Okay, so a nurse instructs a client to use the pursed lip method of breathing. The client asks the nurse about the purpose of this type of breathing. The nurse responds, knowing that the primary purpose of pursed lip breathing is A, promote oxygen intake, B, strengthen the diaphragm, C, strengthen the intercostal muscles, D, promote carbon dioxide elimination.
All right. This one, I'll not waste time. Okay, I'll not waste time. I said it clearly. Oh, what is it? Okay, I said it clearly, right? So it is D. Okay, right. It's D. All right. So this brings us to the end of COPD, and then we begin asthma tomorrow. So let's do the rationale. So first, lip breathing facilitates maximum expiration for clients with obstructive lung diseases. This type of breathing allows better expiration by increasing airway pressure that keep air passages open during exhalation. Okay, during exhalation. So this brings us to the end of COPD.